Welcome to the Women's Health Group. This session is led by the Ashford and St Peter's Specialist Pelvic Health Physiotherapy team. We are an all-female team that specialise in providing assessment and treatment to those with bladder, bowel or pelvic floor muscle dysfunction. Please note that this advice video is only to be used by patients referred into the Pelvic Health Physiotherapy service at Ashford and St Peter's Hospital. This session is designed to help you begin your treatment for your bladder, pelvic organ prolapse, or pelvic floor issue straight away. It guides you through the common symptoms people can have and why. We then discuss the starting point in the treatment for these conditions so you can begin trying this advice straight away. You should also have a one-to-one session booked with a pelvic health specialist physiotherapist to complete a full assessment, provide a diagnosis, and tailor your treatment plan. If you do not already have this booked, please call us to arrange this. The number can be found on any email correspondence and also at the end of this video. In today's session, we will discuss the common risk factors for bladder, bowel, and pelvic floor muscle dysfunction. We will talk through the common types of incontinence and pelvic organ prolapse so we can see how and why we develop each of these problems. Then we will move on to the key things you can do to start improving your symptoms. We will discuss the pelvic floor muscles, their role in bladder and bowel function, and how to exercise these muscles correctly. First of all, it is useful to explain some of the female anatomy and the role of the pelvic floor muscles. This can help to understand how and why we develop symptoms. We require support of the pelvic floor muscles to reduce the chance of bladder and bowel dysfunction. We will discuss how to strengthen these muscles later in this video. In this picture, we have the female pelvic anatomy. This diagram represents a lady standing on her side with the front on the left of your screen and her back and bottom on the right of your screen. On the left of the picture, we can see the bladder and the urethra where we pass urine from. In the middle, we can see the vagina, and at the top of the vagina, we see the uterus or the womb. On the right, we see the anus, the rectum, and the bowel where we store and pass feces. The pelvic floor muscles are the group of muscles that are at the base of the pelvis. They are shown in this picture by the deep pink band running horizontally underneath the pelvic organs. They attach from your tailbone at the bottom of the spine and pass around your anus and rectum, around the vagina and the urethra, and all the way up to the pubic bone at the front. These muscles are like a hammock and they help to support the organs that rest above. When these muscles tighten, they close the passages from the bladder and bowel and lift the pelvic organs, including the rectum, uterus, vagina, and the bladder. Our pelvic floor muscles need to be strong enough to allow us to control when and how we pass urine and feces. They also support the pelvic organs and reduce the chance of a pelvic organ prolapse. We know that 2 in 3 women experience urinary incontinence. 1 in 2 experience a pelvic organ prolapse, and 1 in 10 experience fecal incontinence at some stage during their lifetime. There are many factors that contribute to us developing these symptoms. Sometimes we may develop them suddenly, but for many, the symptoms develop over a period of time. There are some factors that increase our chance of developing these symptoms as they weaken or add stress onto the pelvic floor muscles and other structures that support our pelvic organs. These factors are pregnancy and childbirth. This is due to a combination of added weight on the organs and the pelvic floor muscles, hormonal changes that soften and stretch the vaginal walls and pelvic floor muscles, plus the process of vaginal delivery can further increase these changes. The more pregnancies we have, the more this can be a factor. Menopausal changes, the reduction in estrogen levels in the tissues around the vagina and pelvic floor can cause it to become weaker. Obesity or being overweight, This is due to the added pressure and load through the organs and the pelvic floor muscles. Constipation. This is largely due to having to strain to empty our bowels, leading to an increased pressure and subsequent weakening of the vaginal walls and pelvic floor muscles. Family history of bladder or bowel issues or prolapse. There is both a genetic and a habitual link that develops from when we are young. Chronic coughing. This places added pressure on the pelvic floor muscles to support the organs whilst coughing. Heavy lifting. This is due to the added weight and downward pressure through the pelvis. Increasing age. This is as our pelvic muscle strength tends to decline as we become older. Previous pelvic surgery. This is due to the changes to the support structure of the organs and the pelvic floor muscles. And hypermobility, as the muscles and the supporting tissues for the pelvic organs have increased elasticity and provide less natural stability. We discussed earlier that 2 in 3 women experience urinary incontinence and 1 in 10 experience fecal incontinence. There are different types of incontinence, and if you are having problems with this, it can help to understand what type you might have, as the treatment for them varies. Stress incontinence is the most common type of urinary incontinence. This occurs when a pressure or stress is placed on the bladder, and pelvic floor muscles are not able to keep the urethra closed whilst this stress is occurring. Examples of this are leaking when we cough, laugh, sneeze, run, jump, or do a sudden movement. These activities cause a rise in pressure in the abdomen where the bladder sits, and if this rise in pressure is stronger than the muscles and the support that closes the urethra, then we will leak urine, as is shown in the picture. Stress incontinence is often made worse by being overweight, having a persistent cough, smoking, being constipated, and having had previous pelvic surgery. Urge incontinence is the second most common type of urinary incontinence. This occurs when we get a strong urge to pass urine but cannot control it enough to reach the toilet in time. Let's first think about how our bladder works normally. The bladder is a muscle. It can help to think about it like a balloon. It is relatively flat and relaxed when there is nothing in it, and as the bladder fills, the pressure in it should steadily rise. Our bladder fills with urine at a relatively constant and steady rate, but it can be sped up and slowed down slightly depending on our fluid intake. A normal female bladder holds approximately 400 to 600 ml of urine when it is full. We may get this amount or close to it first thing in the morning as we have held longer overnight, but it is not usual to hold until this point regularly. As our bladder fills, we get a few signals from it at varying intervals. We often get what we call a first urge or warning from the bladder when it is about 1/3 full, about 150 ml. This should be an urge that we can and should ignore. If we were busy or distracted, we may not even notice it. We should get a second urge or warning from our bladder that it is filling when it is approximately half full, around 250 ml. This is where most of us would listen to this urge and begin to look for or go to the toilet. However, remember that we are still only half full, so we should be able to continue to hold on for a while. We will continue to get more regular urges or reminders from our bladder, but if there is no appropriate place or time, then we could continue to hold, but this would become more uncomfortable and harder to distract from. If our bladder is not functioning normally and we are getting urinary frequency, where we have to pass urine more than 8 times a day, or urinary urgency or incontinence, then the bladder has often lost this normal filling process, and we get the warning signals much too early in the bladder filling process. This means we either pass more frequently or the urges become much stronger, and so we find it hard to control them and can get leakage. Sometimes this leakage can be triggered by things such as feeling cold, putting your key in the front door, or seeing the toilet. This is often because our bladder has learned to associate going to the toilet with these activities or times. Urge urinary incontinence can be caused by an overactivity of the bladder muscle, giving us irregular and strong bladder urges. This is called detrusor overactivity. This can only be confirmed by a bladder function test called urodynamics. More common symptoms can develop over time through poor bladder habits, which irritate the bladder, such as the things we drink, our patterns of drinking, or our patterns of toileting, such as using the toilet just in case. It can also be coupled with a weakness in the pelvic floor muscles, making it harder to hold larger volumes in the bladder. As we discussed at the beginning, a common problem women develop that can occur on its own or alongside incontinence is a pelvic organ prolapse. This is when the vaginal wall becomes weaker and prolapses down into the vaginal canal. This can lead to one or more of the pelvic organs resting lower in the pelvis. It is not life-threatening but can become bothersome for some people. This often happens over a period of time for most women, but it can happen suddenly. This is more common after childbirth. Some women describe it as a sensation of something coming down inside the vagina or a heaviness or bulge. Some have bladder or bowel problems alongside this, such as the feeling of not being able to empty the bladder or bowel completely, having to strain to empty, urinary or fecal incontinence, or an urgent feeling to get to the bathroom are all common symptoms. Some also report they feel discomfort or a block when having sex. However, it is not uncommon to have a mild prolapse and not be aware of it at all. Pelvic organ prolapse is a change in the position of the pelvic organs, and in a moment we have some diagrams of different prolapses at different stages, which can help you to see how this can occur and how this impacts on our bladder and bowel. When we explain why a pelvic organ prolapse can happen, it's often helpful to use an analogy of a boat in a dock. In this analogy, the boat is your pelvic organs that need to be supported to stop them from prolapsing or dropping. The mooring ropes are our ligaments. These are the rope-like structures that hold our organs in place inside the pelvis. The water in the dock is the pelvic floor muscles. These give some lift to the boat or organs from underneath. If both the ligaments and the pelvic floor are doing their role well, the organs or boat stay supported in the dock on the left. If our pelvic floor muscles are weaker, it is like having less water in the dock, and so it places greater pressure on the ligaments or ropes, and over time these would begin to weaken, stretch, and then they too would fail, causing the boat to drop into the dock. We cannot replace our ligaments, however we can strengthen the muscles that support them, our pelvic floor muscles. By doing this, it is like adding water to the dock on the right, meaning the ligaments or ropes do not have to take so much of the strain, and the boat or organs will not rest as low. This first picture shows the female anatomy without any prolapse. This lady is standing side on with her front on the left of your screen and her back and bottom on the right of the screen. On the far left of the picture, we can see the bladder and the urethra. This is where we store and pass urine. In the middle, we see the vagina, and at the top, we see the uterus or the womb. On the far right, we see the anus, the rectum, and the bowel, where we store and pass feces. Notice the position of the organs and that the vaginal walls in the middle have space and are well supported without the bladder, uterus, or rectum resting onto them. The next few pictures will show the uterus and cervix descending. Here we begin to see the uterus sitting lower into the vagina. Now we see the uterus descending further down towards the vaginal entrance. Notice that as it gets lower, it has a greater impact on the vaginal walls, and it can, at times, begin to pull the bladder and rectum down with it. The uterus can descend lower, and for some, it may be seen or felt outside of the vagina if the prolapse continues. We have again come back to our picture without any prolapse. We will now look at a bladder prolapse, which is also called an anterior or front wall prolapse or cystocele. We can see that the bladder on the left is beginning to bulge into the front wall of the vagina. The bladder can continue to descend as the prolapse increases. If this prolapse progresses, it can bulge further into the vaginal wall and rest lower in the pelvis. Notice that as the bladder moves further down, it can create a pouch or pocket in the bladder that rests lower in the pelvis, and this can make it hard for the urine stored here to empty out of the bladder. Sometimes when the bladder descends, it can also cause changes to the position of the urethra, which is the tube leaving the bladder. This can further impact on our continence. The bladder can descend to be seen or felt at or out of the entrance of the vagina. This picture again takes us back to the female anatomy without prolapse. This time we will look at the rectum dropping into the vaginal wall. This is called a posterior wall prolapse or rectocele. If the bowel prolapses from higher up in the abdomen, it is called an enterocele. The beginnings of a posterior wall prolapse, we begin to see a small pouching of the rectal wall towards the vagina. In this picture, we notice it at the bottom of the rectal wall. As the rectum drops into the vagina, it too can create a pouch. This pouch can trap feces and make it more difficult to empty the bowel. If the back wall continues to descend, it can be seen or felt at the entrance to the vagina or resting outside. Pelvic health physiotherapy is recommended as first-line management for all women with urinary incontinence, fecal incontinence, and pelvic organ prolapse. 75% of people who complete physiotherapy will improve, and many feel they do not need any further treatment. Even where other options for management have been suggested by your healthcare provider, it is recommended that physiotherapy is also completed, as it can improve the success of future treatments, such as medication or an operation. We have discussed the common issues that can occur, and now we will focus on what you can do to reduce these symptoms. As we have mentioned, our pelvic floor muscles are key to helping reduce our bladder, bowel, and pelvic organ prolapse symptoms. To understand how to do a pelvic floor contraction, it is useful to look again at the picture of where the pelvic floor muscles are. On this picture, the pelvic floor muscles are the deep pink horizontal line across the bottom of the pelvis. They start at the tailbone, run around the anus, vagina, and urethra, and attach onto the pubic bone at the front of the pelvis. To work these muscles, we must squeeze the muscle in from the anus as though you are winking the back passage closed. Then you should try to continue increasing this squeeze from the anus and pulling this feeling forwards through the vagina and up to the front. It often helps to think of this as though you are gently stopping passing wind and urine at the same time. This movement should start gentle, and you should work on making sure you are not clenching your buttock or tummy muscles. The movement should come from the anus and vagina predominantly. It is best to get this technique right first and ensure a good quality squeeze of the muscles before you worry about squeezing stronger or longer. This muscle must be exercised in two ways. Firstly, by squeezing and holding for up to 10 seconds. This strengthens the part of the muscle that supports you throughout the day to keep the organs held up, provides stability when we are standing, sitting, and moving, and helps us to reach the toilet in time. Secondly, we need to exercise the muscles by squeezing quick and strong. This part of the muscle adds extra support when we cough, laugh, sneeze, or do a sudden movement. The long holds are explained here on the left of the screen. You should squeeze the pelvic floor muscles, as we just explained in the previous slide, and then try to hold them steady for up to 10 seconds. You should not hold your breath whilst you're doing this. And if you find it hard not to hold your breath, it can help to count out loud up to 10 seconds as you hold these muscles. This will help to keep your breathing steady. A lot of people cannot hold for 10 seconds straight away and need to build up to this. So you may be better to start at a few seconds holding and then steadily build up to 10 seconds over a period of weeks. Remember, it is important to first ensure the quality of the pelvic floor squeeze before you build this holding time. You should rest for a few seconds between each squeeze and aim to complete 10 of these holding contractions in a row. The second way to exercise the muscle is to squeeze it strong and fast. This is done by short holds. Imagine your muscles are an elevator and you're lifting it up to the top floor, and as soon as you get to the top, you let go. You must let the muscle relax completely when you let go. Wait 2 seconds and then repeat this again. You should do this between 10 to 20 times. These two exercises combined are one set of pelvic floor exercises. You should aim to complete this 3 times a day. It often takes 3 to 4 minutes per set. Often women find it is not the process of doing the exercises that is challenging, but more that they forget to complete them. You could try to do them at a set time each day to help it more routine, or you may find associating it with another task in the day helps to jog your memory, such as making a drink or brushing your teeth. In addition, the NHS has a pelvic floor muscle app that can be downloaded to your phone or tablet if you have one. On this, you can set up reminders for your exercises and adjust the settings so it counts you through your exercises and helps to ensure you get them all done. In this next section, we will discuss the things that you can do to help improve stress incontinence, urinary urgency, urge incontinence, and fecal incontinence. For all of these conditions, it is important that you complete regular pelvic floor muscle exercises, as just explained. You should eliminate or significantly reduce your caffeine and alcohol intake, as these can aggravate symptoms. It is normal to drink between 1.5 to 2 litres of fluid in total per day. This should be spread evenly throughout the day and limited to 1 glass or cup of no more than 300 ml at any one time. If you are having problems with waking in the night to pass urine, you should also stop fluids 2 to 3 hours before going to bed. We should not drink through the night if we wake up. If your mouth is dry in the night, you can rinse it with water or just take a small sip only. As well as strengthening our pelvic floor muscles, we need to make sure they work at the right time. Just before we cough, sneeze, or lift anything heavy, we should actively squeeze our pelvic floor muscles in so they are holding ready for the activity. This can instantly reduce leakage. For all of these problems, we know that being significantly overweight can make them worse. Losing weight to return to a healthy body weight can reduce and often even eliminate symptoms. If you are a smoker, stopping smoking can reduce your bladder symptoms. If you have bladder urgency, which is where you get an urge to pass urine suddenly or with little warning, or urge incontinence where you leak urine due to this sudden need, then bladder retraining can help you to improve this. It takes 6 to 12 weeks of following this advice consistently for it to make a difference, so it is important to stick at it. This program aims to help your bladder gradually hold more urine. Remember, it is normal for our bladder to get its first urge or twinge to pass urine when it has approximately 150 ml in it. We should be able to ignore this initial sensation and delay until we get a second urge or bladder twinge that we need to pass urine. This is often being able to delay about 20 minutes. A usual wee should be around 250 ml. It can help initially before starting this program to complete a bladder diary. This charts your fluid in and out throughout the day. There is one in the pack of information sent to you with this video link. Once you have completed your bladder diary, you will be able to see the volume of urine you are passing. You should aim to have volumes of around 250 ml or more each time you pass urine. You can build towards this by gradually extending the time between each time you pass, or by setting a time to hold on for once you get the urge to go. For example, waiting 5 minutes extra once you need to pass urine. This length of time can steadily be increased over a period of weeks. Whilst completing bladder retraining, you must also be sure you are sticking to the core things we said previously about spacing your fluid intake throughout the day and drinking 1.5 to 2 litres spread evenly throughout the day, and avoiding fluids that are irritable to the bladder. The table here shows fluids on the left that are less likely to irritate the bladder. These include water, squash, decaf tea and coffee, most herbal and fruit teas, milkshake and milk. On the right, you can see drinks that are highly likely to irritate the bladder. These include caffeinated drinks such as tea, coffee and green tea, citrus juices, tomato juice, fizzy drinks and alcohol. It is particularly important to reduce or eliminate your caffeine intake. Caffeine not only irritates the bladder and causes us to get a stronger urge to pass urine with less warning, but it also acts as a diuretic and means we produce a greater volume of urine. Some research has shown that women who drink 3 or more caffeinated drinks are 70% more likely to have bladder problems. We understand that when you are receiving very strong urges from your bladder, it can be incredibly difficult to delay the urge to pass urine. This list of things can help to calm the urge and keep you in more control. Remember, it may not work the first time, but over many weeks of trying and being consistent, most people find it helps them to improve. So when the urge to pass urine is strong, you should stop and either stand still or sit down. It is important to keep calm and relaxed and not to hold your breath. If we panic, our adrenaline rises, and this can cause the bladder urge to become stronger. Try to distract yourself. The more we focus on that desire to wee, the harder it is to control. You could distract your mind temporarily by counting backwards in 3s from 1,000, or saying the alphabet backwards. These are silly tasks, but can often take your mind off the desire to wee. Others find absorbing themselves in a to-do list or another task, such as sending a text or email or writing your shopping list, helps to take their mind off of things more. Some people find gently squeezing their pelvic floor muscles, about 50%, for a few repetitions can help. Many notice that some pressure on the perineum, this is the area of skin over the vagina and anus, can help to calm the sensation of needing to wee. You can do this by crossing your legs, sitting on a firm surface, or perching on the edge of a table or an arm of an armchair, or by physically placing your hand over this area. The final trick that can help is curling and uncurling your toes so they bend and straighten. This sounds odd, but many people have found it helps calm the urges from the bladder, as this movement uses similar nerve pathways to the bladder. You should try to use some of these strategies when you need to calm the urge from your bladder or when you are trying to hold on a bit longer. These tips can help to reduce the strong urge to a more manageable level. Use them for a short period to help the bladder urge to settle slightly, then calmly walk to the toilet or continue to delay the feeling, depending on your aim at that time. You can see more details on this bladder retraining program in your information pack that was sent with this video link. If you have been diagnosed with or think you have a pelvic organ prolapse, then the following advice can help to improve your symptoms. It is key to remember that the more pressure we place on our pelvic organs without enough support will lead to greater chance of the prolapse and your symptoms increasing over time. Therefore, taking measures to increase our pelvic floor strength and reduce the load on it can not only reduce current symptoms, but also help to reduce progression of symptoms in the future. This means that the top of the list for improving a prolapse is usually improving your pelvic floor muscles. This involves working on the exercises we discussed earlier to gain muscles that are stronger and can work for longer before getting tired. You should complete the pelvic floor exercise program we discussed earlier for 4 to 6 months, a few times a day, and then maintain this strength by completing one set 3 times a week after that. This will help to prevent your muscles from weakening over time. You should maintain healthy bladder and bowel habits by ensuring you drink the correct volume of fluid and avoid constipation, as straining to empty your bowels is a key factor in increasing prolapse. We will discuss ways to reduce straining and constipation in a moment. Prolapse is made worse by increased pressure or weight through the pelvic organs. You can help to reduce this by avoiding or minimizing any heavy lifting. For example, asking for help if needed, or breaking the task down into smaller stages, or using a trolley to help move heavier items. If you are overweight, reducing this through a healthy diet and exercise can reduce the pressure through the prolapse. If you suffer with a regular cough, then taking steps to reduce this will take further pressure off of the organs and pelvic floor muscles. You may need to see your GP to discuss the cause of your coughing and see if they can help suggest ways to reduce this or review your current management for this. We have already discussed the needs for exercising our pelvic floor muscles and exercising to lose weight, but exercise to strengthen our body as a whole can also reduce symptoms of prolapse by helping us to gain greater abdomen and core strength. Pacing your activity can also help to reduce the pressure placed on your pelvic floor muscles and prolapse. Pacing activities that aggravate your prolapse symptoms, such as prolonged period of time on your feet, bending, gardening, lifting, housework, and sport, can help to even out the pressures and allow your muscles time to recover. So try to space out these activities through the day or the week. For some, it may be that their symptoms of prolapse build as the day goes on, and so having a sit or a lay down for 10 to 15 minutes in the middle of a day can be enough to reduce the discomfort. The final note for those with prolapse is to reassure you that having sexual intercourse will not increase the prolapse. For some, it may be uncomfortable, but this is often helped by using a lubricant and trying out different positions that may be of more comfort. The final thing to discuss that has a big impact on our pelvic floor is our bowel function. It is normal for us to open our bowels from 3 times a day to 3 times a week. It is important to ensure we have bowel motions that are not too loose, so we can hold on to them easier when it is not appropriate to empty, but also that they are not so firm that we strain to pass them. This chart shows different consistencies of feces. You should be aiming for type 3 to 4 on the chart, which is like a sausage and smooth. To make this more likely, you should ensure you take in enough fluid, a total of 1.5 to 2 litres or a little more if you're exercising that day. You should also ensure an adequate fibre intake. The NHS recommends 30 grams of fibre a day. If you're struggling with constipation, it can be useful to keep a food diary and add up your approximate fibre intake for a few days and see if you're achieving this. Ways to increase your fibre intake are eating at least 5 fruits and vegetables a day, switching to whole grain carbohydrates such as whole grain bread, whole wheat or brown pasta, and whole grain rice, as these have a much higher fibre content than their white counterparts, eating high fibre cereals, and including nuts and seeds into foods you prepare or as a snack. Most people find they have the best chance of emptying their bowels approximately 20 to 30 minutes after a hot drink and a meal or snack. So trying to make time in your day to allow yourself to sit relaxed on the toilet for 10 minutes after you have done this can really help. When we are having difficulty emptying our bowels, it is also important to think about the position we adopt on the toilet. As we can see from the picture on the left of your screen, our rectum is not straight, but instead has an angle or a corner in it. By sitting on the toilet in more of a squatting position, we reduce this angle in the rectum, and this makes it easier to empty, as we do not have to push the feces round a corner. To do this, we need to raise our knees up higher than our bottom when we are on the toilet. We cannot squat on our Western toilets, so the best way to do this is place a step under your feet. You can see in the pictures on the right. Placing our feet on the step and leaning forwards with our back nice and straight so that our elbows rest onto our knees can greatly increase the ease of emptying the bowels. If you follow these measures and the bowels are still difficult to empty, then it is important you avoid straining, as this will weaken the muscles. You should wait for 10 minutes, and if you could not empty without straining, try to come back later. You should also inform your physiotherapist of this difficulty when you have your one-to-one appointment, as they may be able to help you further. We have come to the end of the advice for now, and we should consider the next steps in your physiotherapy treatment. This session has aimed to start you off with understanding your symptoms and why they are occurring. We have also provided you with the key advice that can either resolve or begin to improve the problems you are having.
Today is the start of your treatment. Please remind yourself of the key areas we have suggested for your specific symptoms and start following these now. As a reminder, The key areas for everyone to begin are 1. Your pelvic floor exercises. These should be completed a few times a day and will take time to build strength. It is important that you keep going for at least 4 months daily to see the best changes. 2. A fluid chart. This should have been sent to you either by post or email when this session was sent. You should complete this in full. Complete it for 3 days. You should measure when, what, and how much you drink in millilitres, as well as when you pass urine and how much you pass, again in millilitres. Additional guidance for completing this is attached to the bladder diary. 3. Think about your fluids. Try to ensure you adapt to the things you are drinking so that you are drinking the correct amount and they are fluids that are least likely to irritate your bladder. 4. Improve any constipation. If you strain to empty your bowels, try to follow the steps listed earlier to improve this. In addition to this session, you will also receive a one-to-one assessment booked with a specialist pelvic health physiotherapist. You will be called to make this appointment once you reach the top of our waiting list. In this assessment, we will talk to you about the problems you are having, offer a vaginal examination to assess you, provide a diagnosis, and discuss your treatment options with you. We will then tailor a treatment plan to meet your specific needs. We aim to answer any questions you may have about the information in this session, potential cause of your symptoms, and options going forward. Please make sure you have your fluid diary and a list of medications you are currently taking with you for this session. You should have received written information about the vaginal examination in the correspondence sent out from our team. We are happy to discuss this with you in more detail at your appointment if you have any concerns. If you do not wish to proceed with physiotherapy, you should still attend this session for assessment and further options can be discussed with you. Ask that you start following the advice given in this session. Complete your bladder diary and bring this to your first one-to-one assessment session. You will be contacted once you reach the top of our waiting list to book your assessment session. If you have any questions that you need to ask our reception team regarding your future booking, then do contact us by calling on the number listed on screen or emailing on the email address listed. Please be aware that once your one-to-one session is booked, if you cannot attend, you should call us to let us know. If you do not attend the session and do not call within 2 weeks, then you will be discharged back to your GP and a new referral will be required.
Thank you for watching. We hope this information helps you to start improving your symptoms, and we look forward to speaking with you at your one-to-one assessment.